patient how fast it grew, whether it was a slow growth or a fast growth. Then you have to ask whether there's any pain associated with the swelling, and you have to ask whether it is a solitary swelling or any other swelling associated with it on the neck. And you have to ask whether there are any systemic symptoms of hypothyroidism, symptoms of hyperthyroidism. The symptoms of hypothyroidism are fatigue, lethargy, hoarseness of voice, constipation, and general sudden gain in weight. But the most common one is fatigue and lethargy. Constipation is a usual accompaniment, and as women will usually notice a sudden gain in weight. So these are the symptoms of hypothyroidism, and there will be cold intolerance. Patient will have an intolerance for cold. Uh, Symptoms of and late symptoms of hypothyroidism is loss of hair. They complain of falling hair and loss of hair over the lateral one third of the eyebrows. Okay. Then the symptoms of hyperthyroidism are cold and sweaty palms will be there. Patient will complain of palpitations, heat intolerance, sweaty palms will be there, and patient may notice tremors on the fingers when he may notice that his fingers are always trembling, and patient will also have nervous symptoms. They will always be anxious, and he'll have diarrhea, and he'll have an increased appetite. But in spite of the increased appetite, there will be a loss of weight. There is no gain. In spite of the increased appetite, patient will be losing weight and he'll become thin. And he will have diarrhea also. In hypothyroidism, you will have constipation. In hyperthyroidism, you will have diarrhea. So these are the symptoms of hyperthyroidism. Patient has heat intolerance, cold, sweaty palms, tremors, and palpitations, and he is always anxious. And so we have covered the symptoms of hypo and hyperthyroidism. So this is in short about the history. Then you ask about the swelling, the characteristics of the swelling, how fast it grew, how is it associated with any other swelling, and the swelling, is it associated with symptoms of hyperthyroidism or hypothyroidism, and you also ask whether the swelling is associated with pain. After asking the history about the swelling, you come to examination of the swelling. Like I told you, when you are examining a thyroid patient, you have to put a stool, ask the patient to sit on the stool. Okay, for examination, for inspection, you have to stand in front of the patient, ask the patient to slightly extend the neck. Slightly extend the neck so any swelling on the neck is visible here. You stand in front of the patient, ask the patient to sit on a stool, and you stand in front of the patient. On exam, you have to examine the patient in daylight, take him near the window, put the stool near the window so that in broad daylight you examine. You see for site of the swelling. Site is where on the neck the swelling is, and shape of the swelling, size of the swelling, the surface of the skin over the swelling, and anything present on the skin, presence of scars, sinuses, or dilated veins, or any dimpling, any puckering or tethering seen on the swelling, you have to see. This is all inspectory findings. So you will first see the site of the swelling in relation to the neck has a few triangles. Okay, this is the midline of the neck. This is the midline. Then you have the anterior triangle and the posterior triangle. The anterior triangle and the posterior triangle are divided by this muscle, which is the sternocleidomastoid muscle. The sternocleidomastoid muscle divides the lateral aspect of the neck into an anterior triangle and a posterior triangle. Then you have the superior belly of the omohyoid and the inferior belly of the omohyoid. It divides the triangle into the carotid and the muscular triangles. The carotid triangle and the muscular triangles. Then here, this space, you have the submental triangle and the submandibular triangle. You have one, the submental triangle is just beneath the chin. The submandibular triangles are beneath the jawbone. This side one and this side one. The boundaries of the triangle you can revise in your anatomy lesson. You have to learn the boundaries of the triangle. So you will tell the swelling is in which triangle. In relation to the triangles of the neck, you will say where the swelling is. In case of a thyroid swelling, it will be found on the midline. The isthmus will be in the midline, and the lobe, right lobe and the left lobe enlargement will be found occupying the carotid and the muscular triangles. The isthmus will be overlying the cricoid cartilage, and the superior pole of the thyroid will reach up to the thyroid cartilage, So any extent of any swelling, you should say in relation to bony prominences on the neck and on the face. So the inferior border of the thyroid swelling, you should say in relation to the superior surface of the sternum. The superior surface of the sternum, how many centimeter above the superior surface of the sternum, you can feel the inferior border. So the inferior border you should tell in relation to the superior surface of the sternum. Then superior border, how many centimeters below the thyroid cartilage. Then if any swelling is coming till here, how many centimeters it is from the mastoid process. This mastoid process, from here, how many centimeters it extends below the sternocleidomastoid. So you tell the extent of the swelling in relation to the bony prominences on the neck and on the face. So, and the size of the swelling should be measured with a inch tape. Any student going to the ward should have an inch tape and a skin marking pencil, a torch, a transilluminoscope. These are the things which help, tools which will help you to examine any swelling. So, with an inch tape, you measure the extent of the swelling. Most extent, the transverse extent will be from the sternocleidomastoid, this side to this side. Either it is stopping short of the anterior border of the sternocleidomastoid, or it is going beneath the sternocleidomastoid and reaching behind the sternocleidomastoid muscle. If the swelling is reaching behind, then it's a really huge swelling. But most thyroid swellings will stop short of the anterior border of the sternocleidomastoid on either side. And superior extent till the thyroid cartilage, inferior extent, how much below does it beneath the sternal border? If it goes beneath the sternal border, then there is retrosternal extension of the thyroid. So you stand in front of the patient, you examine, ask her to just extend the neck a little. You examine first the skin over the swelling. You see the extent of the swelling. Measurement comes in palpation. On inspection, you see the height of the swelling, whether it's in the midline or whether it's lateral to it. It's not in the midline, whether it's a butterfly shaped swelling. Most diffuse goiters will have a butterfly shape because the thyroid gland as such has a butterfly shape. Whether it's a butterfly shaped swelling, whether there is any nodularity seen, whether multiple nodules are visible on inspection, whether nodules are visible on both lobes or only one lobe is enlarged, or if the isthmus is also enlarged. All this is, you can get this information from inspection. Then see the skin over the swelling, whether there are any scars, any sinuses, any enlarged veins are present. Sometimes enlarged veins will be seen as bluish lines running over the swelling. And you can see if there's any bossellation or nodules. Multiple big nodules will also be visible as a bossellated swelling. Bossellated means the surface is nodular. Inspectory finding, bossellated means the surface is nodular. Then you see if there's any other swelling separate from the thyroid swelling. You see any other swelling on the neck, either in the anterior triangle or in the posterior triangle. You separate from the thyroid swelling. You see if any other multiple swellings are there. Then after that, you have to go behind. After the inspection, you see the size of the swelling, shape of the swelling, extent of the swelling, surface of the swelling, and the skin over the swelling. After you inspected, you have to palpate the swelling. For palpation, you have to go and stand behind the patient. That's why I said you seat her on a stool. You stand behind the patient, and with your fingers, both thumbs on the nape of the neck, with both of your thumbs on the nape of the neck, ask her to flex the neck forward. When you flex the neck forward, you are relaxing the deep cervical fascia. When she flexes the neck, the deep cervical fascia is flexed, is relaxed. Then with these four fingers, the four fingers or the ventral aspect, you palpate like this. Your thumb should be behind the neck, flexing the nape of the neck, and with these four fingers, with both the hands, you have to ask her to flex the neck and Like this, you will be palpating both the lobes and also the isthmus. Like this, you will be palpating. Both the fingers will be back. And when you see for a carotid pulse, you should not feel both the carotid pulses at the same time. The carotid pulse is felt across the C4 transverse process. You should not feel both the carotids at the same time. You should one side you first palpate, then the other side. So to palpate, you feel for any nodules. When she flexes the neck, the nodules are more prominent. You can feel for nodules. You can see the extent of the swelling, and you can also feel the lateral aspect of the neck to see if there are any lymph node enlargements, because some thyroid malignancies are associated with lymph node, like papillary carcinoma of the thyroid. You can have lymph node enlargements, but the thyroid may sometimes be not palpable. Papillary carcinoma, sometimes the lymph node metastasis or the lymph node secondaries can be huge. You can have huge nodal enlargement without any enlargement of the thyroid gland. Like that also you can have clinical scenario where the thyroid is not palpable, but huge enlarged lymph nodes will be there, which are due to secondaries from the tiny focus of papillary carcinoma in the thyroid. So, palpation is relaxing the neck. You flex the neck forward, stand behind the patient and palpate. And also feel if the carotid pulsation on both sides, first on one side, then on the other side. Then you come back in front, and if you feel that this is a multinodular goiter, to see the nodules more prominently, there's another method called Trial's method of examination. You have Pisello's method of inspection is to make the gland more prominent. You keep both the hands behind the head and ask her to extend the neck. You keep both hands like this behind the head and ask her to extend the neck like this. Then any swelling in the front of the neck becomes more prominent. So you stand in front and see the prominent swelling. Sometimes nodules will become prominent. This is called Pisello's method of examination. Then Kryle's method of examination is a type of palpation. With the thumb of your right hand, you ask her to extend the neck like this, like Pisello's method, let her extend the neck. Then with your thumb, you palpate the nodules. Come and stand in front of the patient. In Kryle's method, you don't stand behind the patient. You come and stand in front of the patient, and with your thumb, you palpate the nodules when she extends her head like in Pisello's method. Okay. There's another method of examination called Lahey's method. Lahey's method also, you have to stand in front of the patient. You stand in front of the patient. Lahey's method is for palpation of the lateral lobes. For Kryle's method, you can, when the, in Kryle's method, you can palpate all the nodules with the thumb. In Lahey's method, you stand in front of the patient, ask her to extend the neck a little, and then to palpate the right side of the patient with your right hand, you push the lobule, like the right sided swellings of the patient. With your right hand, you push the lobule a little to the right side, then you palpate with your left hand. You are standing in front of the patient. With the left hand, you see the posterolateral aspect of the lobe. To see on the left side, with your left hand, you push the lobe like this, and with your right hand, you palpate the posterolateral aspect of the lobe. So in Lahey's method, you can palpate the posterolateral aspects of the right or the left lobule of the thyroid. In a hugely enlarged thyroid, when you want to palpate the posterolateral aspect, you can use the Lahey's method of examination. To examine the front of the thyroid, you can use the Kryle's method. To extend and then palpate with the thumb of your right hand, you can palpate the nodules like this. Lahey's method for examination of the posterolateral aspect of the lobe, you make the lobe more prominent like this. Right side with your right hand, you push the lobule like this and then palpate with your left hand. For the left side, with your left hand, you are standing in front of the patient. You push it like this and then palpate with your right hand. So that is Lahey's method of palpation. Then before any palpation, you should see if it's warm and tender. It's always like any swelling before palpating. First, when you place your hand, don't place the palm of your hands. You palpate with the back of your hand and see if it is warm and tender. If it's an inflammatory swelling, it will be warm and tender. If it is a very vascular swelling, warmth will be there, tenderness will not be there. If it's an inflammatory swelling, acutely inflamed thyroid abscess, it will be warm and tender. If it is toxic goiter, which is very vascular, there will be warmth, but there won't be any tenderness. So after palpation, you confirm the size, extent of the swelling. You have measured the superior extent and the transverse extent. You have measured with an inch tape and you have recorded it in your paper. Then you have to auscultate the swelling. Before auscultation, there is percussion. In thyroid, you don't percuss over the thyroid. For percussion, you do when you don't see the lower border of the swelling. On inspection, also, you should to ask her to swallow. When she swallows, the lower border of the swelling will be seen moving upwards. The thyroid swelling, whole of the swelling will move upwards, and you can see the lower border of the swelling. If you don't see the lower border of the swelling, then you can assume that there is a retrosternal extension of the thyroid swelling. So, on palpation also, you confirm whether you can palpate the lower border of the swelling. Supposing you can't palpate the lower border of the swelling, then you have to look for Pemberton sign. By Pemberton sign, you ask her to lift both arms and keep the arms close to the ears so that you're occluding the superior inlet. Okay, you keep like this and wait for 5 minutes. If she develops venous congestion over the face and the neck, then you can assume that there is retrosternal extension of the thyroid. When the patient swallows, on inspection and on palpation, if you cannot see or feel the lower border of the thyroid swelling, you look for Pemberton sign. Pemberton sign is like this. You ask her to raise her whole hand and close to the ears so that you are occluding the superior inlet. So, and wait for 5 minutes. If she develops venous congestion over the face and the neck, then you can assume that there is a retrosternal extension of the thyroid swelling. In percussion, you have to percuss over the front of the sternum, this place. Normally, you percuss and see what note you have. In case of retrosternal extension, this resonant note will not be there. You will have a dull note. So, this is how you percuss over the anterior aspect of in the midline, anterior aspect of the sternum. If you get a dull note, then you can assume that you have a large retrosternal goiter. You don't percuss over the thyroid. You percuss over the anterior aspect of the midline of the sternum. Okay. Then in the upper part of the sternum, you don't have a large extension to the middle of the sternum. You can only have in the upper part of the sternum. So this is where you percuss. If you get a dull note, you assume that you have a retrosternal extension. And after Pemberton sign, you have to do auscultation. All vascular thyroids, you will have a bruit over the superior pole of the thyroid. It's the superior pole which is very vascular. To keep you the bell of the diaphragm over the superior pole of the thyroid, if you have a bruit, you can assume that this is a very vascular thyroid. It is mostly bruit and is seen in toxic goiters. Toxic goiters are very, very, very vascular. The thyroid as such is a very vascular organ. You have a rich plexus of veins in the Berry's capsule. The Berry's capsule is the facial capsule around the thyroid. You have a rich plexus of veins in the Berry's capsule. So any thyroid swelling has a propensity to bleed, and more so the toxic goiters. The toxic goiters are even more vascular. So if you touch a toxic goiter itself, it will bleed. That is why when you operate on a toxic goiter, you have to do a pre-op preparation with Lugol's iodine to reduce the vascularity of the swelling, so that it doesn't bleed so much when you operate on the thyroid swelling. You give Lugol's iodine for pre-op preparation of vascular goiters to reduce the vascularity, so that on table the bleeding is less. The point in giving Lugol's iodine is to reduce the vascularity of the swelling. Okay. So you have come to auscultation. So that completes the examination of the thyroid. To look for the peripheral signs of hypothyroidism and hyperthyroidism. Signs of hypothyroidism are, you look and see if there's any loss of the lateral 1/3 of the eyebrows. It will be present in hypothyroidism. It's called madarosis. It will be there in hypothyroidism. And any recent weight gain. Recent weight patient would have suddenly become plump and there is loss of hair and thinning of hair, the receding of the hairline, loss of hair and thin hair and dry and brittle hair will be there in case of hypothyroidism. In the skin also there will be a yellowish tinge. That is called a carotenemia. Carotenemia will be present in hypothyroidism. You will have a yellowish tinge to the skin. Suddenly there will be weight gain. Patient will be complaining of fatigue and lethargy. Then you can see baggy eyelids with xanthelasma. Baggy eyelids with xanthelasma is deposition of lipids. You will have some yellowish deposits with baggy eyelids. The face will be full and there will be pouting lips. There's a figure of a lady in Bailey and in this book called Bailey and Love. There's in the chapter on thyroid swellings. There's a figure of a lady with hypothyroidism. You just see that and you will never forget about the features of hypothyroidism. The lady will have pouting lips, face will be nicely puffy, eyelids will be puffy, and there will be xanthelasma present. And there will be pre-tibial myxedema. Over the tibia, it will be very much edematous, shiny skin will be there, and you have a delayed ankle delay. If you elicit the reflexes, ankle reflex will be delayed, and the knee jerk will also be delayed. That the jerk will be absent, and the reflexes are delayed in case of hypothyroidism. In hypothyroidism, the patient will have intolerance to cold. There will be dry palms. In hyperthyroidism, there will be increased sweating, and the palms will be cold and sweaty. There will be sweaty palms in case of hyperthyroidism. And when you ask the patient to stretch your fingers like this, stretch your hands in front of you and splay out your fingers, you can observe the tremor. To observe the tremor, ask her to stretch out the hand in front like this, play out the fingers, and place a sheet of paper. If she is having tremors, that paper will also tremble. And to see for fasciculations in the tongue, ask her to put out the tongue and see for the fasciculations. And eye signs are there in case of hyperthyroidism. You can appreciate exophthalmos or a proptosis. The eyes will be more prominent and bulging. Exophthalmometer, if you have, you can measure the degree of the exophthalmos. Proptosis is present due to deposition of polymucosaccharides behind the eyeball. You will have a proptosis. The four are constant eye signs, there are many eye signs, but the four which we expect from you are von Graffy sign, Geoffroy's sign, Mobius sign, Stellwax, and Dalrymple sign. Von Graffy is a lid lag. Geoffroy's is absent wrinkling on looking upwards. Then Stellwax is a staring look. Dalrymple sign, you will see all the full cornea will be seen, and in Mobius, there will be absent medial convergence. When you ask her to look, you keep your finger like this and ask her to look, there will be both the eyes should converge medially. This will be absent in case of Mobius sign. So these are the 5 signs which will constantly any examiner will ask you. So these signs you see for in hypothyroidism, and patient generally will be anxious and they'll be complaining of palpitations. Then one more midline swelling in the neck is the thyroglossal cyst. The thyroglossal cyst can be anywhere from the hyoid bone to just over the suprasternal region. Anywhere along this track it can get arrested. The swelling can be slightly lateral also. It will be a rounded small swelling about 2 into 2 centimeter. If you ask the patient to swallow, it will move up with deglutition. And if you ask the patient to put out their tongue like this, you hold the swelling, okay, with your thumb and your index finger. Ask her to put out the tongue. If it is a thyroglossal cyst, you can appreciate the tug. That is, it will move upwards, and with your hands, you can appreciate the tug. So that clinches the diagnosis that this is a thyroglossal cyst. Without holding, you ask her to put out the tongue, you can appreciate that the swelling is moving upwards on protruding the tongue. So that is how you diagnose a thyroglossal cyst. A thyroglossal cyst, because of its cystic contents, it will be fluctuant. Okay? But it will not be transluminant. It can be, you can appreciate Paget's test. It will be fluctuant, but it will not be transluminant. Even fluctuation sometimes is absent if the cyst content is turgid. If it is a turgid cyst, you cannot appreciate fluctuation. Thyroid gland is soft. It can be soft in consistency. Enlarged thyroid can be, a diffuse goiter can be soft, or a multinodular goiter can be firm in consistency. Sometimes thyroid swellings, anaplastic carcinoma can be hard in consistency. Anaplastic carcinoma, hard woody texture will be there. And also in Hashimoto's thyroiditis, hard woody texture will be there. So to give a brief about the consistency of the swelling, palpate your own ear lobule, that is soft. when you palpate your earlobe, this consistency is soft. Then this tip of your nose is firm consistency, and this is hard. This is bony hard, this is firm, and this is soft. So this gives you an idea about soft means it should feel like your earlobe. Firm means it should feel like this cartilage at the tip of your nose. Hard means when you palpate the frontal bone, this is hard. So this gives you an idea about which is soft, firm, and hard. Okay, never forget this in your life. If you get this consistency, you master this, then you will know which is soft, which is firm, and which is hard. So diffuse toxic goiter is soft in consistency, multinodular goiter is firm in consistency, and most malignancies, especially anaplastic carcinomas, can be hard in consistency. And these you have the four type papillary carcinoma, you have differentiated thyroid cancers and undifferentiated thyroid cancer. In differentiated type, you have the papillary carcinoma and the follicular carcinoma of the thyroid. In undifferentiated, you can have anaplastic carcinomas. Then you have medullary carcinoma of the thyroid. The medullary carcinoma of the thyroid and papillary carcinoma of the thyroid have a propensity to spread to the lymph nodes. So you look for lymph node enlargements on the neck. They have a propensity to spread to the lymph nodes. You look for lymph node enlargement in case of papillary carcinoma and medullary carcinoma. So when you have lymph node enlargement, the inference is this may be either papillary carcinoma or medullary carcinoma of the thyroid. If you don't have lymph nodes, but you have secondary, bony secondaries are seen in case of follicular carcinoma of the thyroid. In anaplastic carcinoma, you can have, it spreads by bloodstream. Follicular carcinoma also spreads by bloodstream. So you can have bony metastasis. And one characteristic of thyroid secondaries from thyroid is there will be pulsatile bony secondaries. Pulsatile bony secondaries are seen in case of thyroid cancers. And thyroid swellings as such are more common in female patients rather than in males. Thyroid swellings are more common in female patients rather than in males. And in female patients, this thyroid cancer age group is between 30 to 40 years. Between 30 to 40 years, you can see papillary carcinoma, medullary carcinoma. Whereas anaplastic carcinoma is seen more in the age group above 50 years. Between 50 to 60 or 70 years, you can see anaplastic carcinomas. In males, if you have a thyroid swelling, more probability of it being a malignant swelling is more. In males, if you have a thyroid swelling, the probability of it being a malignant swelling is more. So when you have a male patient with a thyroid swelling, you have to definitely take an FNAC and investigate him. Regarding investigation of thyroid swellings, first is you have to rule out whether he is in the euthyroid with the help of an ultrasound. And if you have lymph node enlargements, you can take a CT scan of the neck also, confirm the, and you can see for the vascularity. Contrast CT will tell you about the vascularity of the swelling. Everything will, the CT will confirm the lymph node enlargements. Initially, you can take an ultrasound. Ultrasound guided FNAC can also be taken from whichever nodule from which you, because suspicious nodule is when you have a cystic degeneration in the solid nodule, that is more suspicious of papillary carcinoma of the thyroid. So you can do an ultrasound guided FNAC and prove that it is a papillary carcinoma. Then you can do a total thyroidectomy for the patient. You cannot differentiate follicular carcinoma from follicular adenoma or benign neoplasm from a follicular carcinoma by FNAC, because FNAC cannot differentiate whether there is invasion of the basement epithelium. That is seen in carcinoma is invasion of the basement epithelium is seen in case of follicular carcinoma, which cannot be diagnosed with the help of a FNAC of the thyroid. But FNAC can show you only a follicular neoplasm. So when you get the FNAC report as follicular neoplasm, you have to do a total thyroidectomy for the patient. Likewise, when you get FNAC gives you for a papillary carcinoma, the treatment is total thyroidectomy. For medullary carcinoma also, it is total thyroidectomy. If there is lymph node enlargement, total thyroidectomy with duct side lymphadenectomy on that side, radical lymphadenectomy on that side. In case of medullary carcinoma, it's the central group of nodes which are enlarged. You will do a total thyroidectomy with the central node dissection which should be done. Okay, so these are about malignant swellings. In case of a multinodular goiter, you will do a near total or a total thyroidectomy and replace L-Troxin lifelong for the patient. Why we are doing total thyroidectomy is because of the risk of recurrence of the swelling. Even for benign swellings, even there is a risk of recurrence. Operating in an already operated field is difficult. The incidence of injury to the recurrent laryngeal nerve is more. In thyroidectomies, the dreaded complication is injury to the recurrent laryngeal nerve, which will cause bilateral injury, will cause stridor. That's a dreaded complication. That's why to avoid this repeat thyroidectomies or a completion thyroidectomy, you initially do of a total thyroidectomy. Replacing L-Troxin is very simple. They just have to take a tablet. The replacement dose is 0.1 milligrams in the morning on an empty stomach. That is very easy to do. To avoid injury to the nerves, you do a total thyroidectomy initially itself. Because the complication of recurrence of a multinodular goiter, recurrence of carcinoma is there. So initially itself, you do a total thyroidectomy. So that is about examination of thyroid swellings. An examination is not complete if you have any swelling on the neck. The examination is not complete if you don't examine the oral cavity. Supposing you have any swelling on the lateral aspect of the neck, if it's a thyroid swelling, you needn't examine the oral cavity if you are sure it is a thyroid swelling. But anyway, since you are examining a swelling on the neck, you have to say one word. Examination of the oral cavity is normal. In case of a thyroid swelling, you shine a torch and see if there's any caries tooth, any other swelling, any ulcer within the mouth. You see if it is present, you should mention, because even thyroid is a swelling in the neck. Any swelling examination of the neck is incomplete if you don't examine the oral cavity. So when you have a swelling on the neck, you have to shine the torch, ask her to open her mouth, shine the torch into the mouth and see what all you will ask her to lift her tongue up and see the undersurface of the tongue, opening of the salivary gland duct. You will see if there's any swelling in the undersurface in the floor of the mouth. You will see if there's any swelling in the gingivobuccal sulcus on either side. You will see the superior surface of the tongue, the lateral aspect of the tongue to see any ulcer is present or not. You will see the arch of the mouth and the palate, the superior surface, the hard palate and the soft palate, and the uvula also you will examine, and you will see the tonsils, everything is normal on. All this should be seen in inspection. So systematically you should see the superior surface of the tongue, undersurface of the tongue. When she lifts the tongue up, you will see the tonsils, everything is normal. When she lifts the tongue up, you will see the floor of the mouth. Then the gingivobuccal, you will use a spatula to remove the soft palate, and the uvula should be examined, and the tonsillar pillars on palpate the oral cavity and see if everything. If everything is normal, you needn't palpate. But if you see a swelling or an ulcer, you have to palpate and see. Okay, so examination of the neck is incomplete without examination of the oral cavity. And if you have any lesion within the oral cavity, you have to examine the neck. These two go hand in hand. If you have a lesion, your case is an oral carcinoma, you have to examine the neck also to see for secondaries in the neck. If you have swelling on the neck, you have to see for if this swelling can be a secondary from the primary in the oral cavity. So you have to examine the oral cavity. Even if your case is a thyroid swelling, you have to examine the oral cavity and say that the oral cavity is normal. Understood? I think that is all about examination of the thyroid. And the detailed class we'll have in the theory class about thyroid swellings, about multinodular goiter, toxic goiter, malignancy. We'll talk in the theory classes. This is about how to examine a thyroid case. What are the history you will ask? How will you examine the patient? And how you will look for the carotid pulse. It's over the felt over the transverse forces of the C4 cervical vertebra, and you will see one side first, then other side. If you see both sides at the same time, patient will have syncope. They will have syncope and they'll faint. So you should do one side at a time. Any doubts? Do you have any doubts? You can ask. Do you have any doubts? I think we can finish the class. Huh? You take
Yes, ma'am.
attendance. Huh? We can finish the class.
Yes, ma'am.
Okay.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank
Thank
you,
you,
ma'am.
ma'am.
Thank you.
Thank you, ma'am. Thank you, ma'am.